I got introduced one time at a school I was doing a talk at as an expert in not feeding people. So what actually kills people? What are the ultimate causes of death according to the World Health Report? If you look at the list, it includes tobacco, elevations in blood pressure, consumption of alcohol, elevated cholesterol, overweight, low fruit and vegetable intake, physical inactivity, illicit drugs, and unsafe sex. None of these things are conditions of excess. They're all conditions of deficiencies or consumption of pleasure trap drugs or products. But if you go to doctors today, including alternative medical doctors or integrative medical doctors, you'd think that everything was caused by deficiencies. Because what people want to tell you about is the pills, potions, and powders and treatments to undertake. Not necessarily what's actually going to work, which is getting rid of the causes of these problems, which are actually the result of people dying. Number 2 on the list I'm going to focus on as it relates to fasting is elevations in blood pressure. And the reason I want to focus on elevations in blood pressure is actually twofold. One, we actually have conducted research on this, so we have data to brag about. But also because blood pressure is a commonly measured phenomena that is very sensitive at indicating all-cause mortality. That is, whether you're going to die or not. And you'll understand why blood pressure is very sensitive as we go through explaining exactly what it is. The blood pressure is measured with 2 numbers, a top number and a bottom number. The top number is called systolic blood pressure, and it represents the pressure of the blood inside your blood vessels when the heart contracts and pushes the blood out through the system. The bottom number, or diastolic blood pressure, represents the pressure of the blood in the vessels when the heart's in its relaxed mode, in between beats. Each of those numbers turns out to be sensitive, important indicators of your health. If the blood pressure is elevated, that condition is called hypertension, and it's the leading contributing cause of death and disability, because it affects and is affected by so many different organ systems. There's lots of things that can make your blood pressure go up. For example, if your heart's not working properly, or the vessels that lead from the heart are narrowed by atherosclerosis, your blood pressure can go up. If the volume of your blood goes up because you're eating too much salt, and so the body's holding into more fluid and increasing the fluid volume, that'll increase your blood pressure. If there's resistance at the kidneys, where the blood all has to flow through your kidneys eventually so it can be filtered and purified, and that's what yields urine. Urine is basically blood that's been filtered. But if there's resistance at the kidney, the blood pressure will go up. So elevations in blood pressure can represent many different organ systems that aren't functioning well. Just because the blood pressure goes up doesn't tell you which organ system might be being compromised, but it tells you that one of those many systems is under stress. There are 200,000 people that die from congestive heart failure each year. That's where the heart muscle itself loses its capacity to carry on this job of pumping your blood. And high blood pressure is the leading cause of congestive heart failure. There are 700,000 people that die every year from a stroke, which is essentially like a heart attack of the brain. And the leading contributing cause of stroke is high blood pressure. The fact is, in industrialized countries, the majority of people will develop high blood pressure if they live long enough to reach retirement age at 65. High blood pressure is responsible for tens of millions of visits to doctor's offices, and it's the leading justification for pharmaceutical intervention. So it's a big, big business. But what's really startling to most people is to find out that the drugs that we spend billions of dollars on are largely disappointing, with the improved outcomes actually only coming for those people that have the very highest levels of high blood pressure. If your blood pressure levels get very high, where your systolic blood pressure is above 160 or your diastolic is above 104, you can measure some benefit from the use of medication at slightly reducing the risk of stroke in those individuals. In fact, that's how high blood pressure used to be defined, as the level at which the dangers from medications are offset by the purported benefits. But the majority of people that actually die from having a heart attack or a stroke from their elevated blood pressure don't have blood pressures high enough to justify the risks of medication. In other words, unless those pressures are very high, the drugs are so dangerous that more people will die from taking the drugs than from the blood pressure. But that doesn't mean the blood pressure is not a risk. In fact, it is. If a person has a blood pressure of 138/88 and they don't have specific end organ target disease, the risk of medication is higher than the benefit of medication, which is why generally physicians won't suggest that you take medications at those levels of what they call borderline hypertension. But that individual has 5 times the risk of dying, for example, from a heart attack as a person that has a more normal level of, say, 110/70. So it doesn't mean that those borderline high blood pressure readings aren't dangerous. They're very dangerous. But the drugs themselves are so dangerous you can't justify their utilization. For every point in systolic blood pressure, the top number, that you reduce it 1 point through diet and lifestyle changes, you reduce your all-cause mortality, that is your risk of dying from any cause, by 1%. So if you bring your blood pressure down significantly through eating better, exercising, improving health, you can dramatically reduce your risk of dying. And that risk goes all the way down to where the blood pressure is at 90/60. So even a person that has a normal blood pressure of 120/80 still has a 30% increased risk of dying from all causes than a person that has a healthy blood pressure of 90/60. Because remember, what's normal is what's average. So if everybody is fat, then being fat can be considered normal. It's not healthy. So you don't necessarily want to be normal in that respect. You want to be healthy. Healthy blood pressure probably is closer to 90/60 on average than 120/80. That's how we manage blood pressure, pills. There's all kinds of pills. There's old, relatively inexpensive pills like diuretics, and there's new, very expensive pills. It turns out, though, when you look at the data on medication, the new expensive pills don't actually work any better in terms of reducing all-cause mortality than the older, less expensive pills. Now, that doesn't keep people from prescribing more of the new pills, but it doesn't make them work any better either. Eventually, the pills don't work, and then there's all kinds of other interventions that are used to monitor and treat high blood pressure. But what actually works in lowering blood pressure has been very well demonstrated. There are literally thousands of studies and what are called meta-analyses, where they do studies looking at hundreds or thousands of other studies to determine what's actually real. What is real is that losing weight lowers blood pressure, and for every kilogram that a person loses, or 2.2 pounds of fat, there's a 1.6 point drop in systolic blood pressure. So if you were to lose a substantial amount of weight, it's possible that you can lower your blood pressure substantially. A vegetarian high-fiber diet, independent of weight loss, is associated with a reduction in blood pressure, as is the elimination of alcohol. Now, some people believe that alcohol is some sort of health food, because that's how they're trying to promote it, that alcohol is some kind of, if you're not drinking now and you have heart problems, you ought to start or something. Of course, it's complete nonsense. Alcohol is actually a significant contributing factor to elevations in blood pressure, as well as a detrimental factor in virtually every other area that you look at objectively. Exercise lowers blood pressure. It turns out that people that engage in regular aerobic exercise, walking, hiking, biking, swimming, these types of activities, can substantially lower their blood pressure, actually almost as big of an effect as any combination of medications. Another very effective way at lowering blood pressure is aggressive sodium restriction. In most of these studies, sodium restriction is talking about limiting sodium to about 1 milligram of sodium per calorie, or less than 2,000 milligrams a day. If you substantially reduce sodium even further, as we do in our programs, which is between 1,000 and 1,500 milligrams of sodium a day, you can get drops actually more substantial than what you would see with the use of medication. John McDougall, in a study that he did at St. Helena Hospital, was able to demonstrate a 17-point drop by combining these factors, by getting people exercising and eating a plant-based diet. And in a study that we did actually with the help of T. Colin Campbell from Cornell University, we took 174 consecutive patients, and we were able to demonstrate a 37-point drop in blood pressure after the fact that they had been on medications had been withdrawn. So in other words, the effects are even bigger because these people come in on medications at a certain baseline. We withdraw the medications, put them through a period of fasting. In this study, fast ranged from 5 to 40 days, and their average drop was 37 points. And in fact, this was the paper, it's called Medically Supervised Water-Only Fasting in the Treatment of Hypertension. If you want to get a copy of this paper, you can actually go to our website at truenorthhealth.com and click on articles, and this study appears on the website. If you look in this paper, though, at people, just the people that had the severest levels of high blood pressure, that is stage 3 hypertension, they started at 180 or greater systolic blood pressure. Those individuals had an average drop of 60 points. So that's the largest effects that's ever been published in the scientific literature. Out of 10,000 papers that we reviewed, we were able to see the largest effects from doing nothing. If you put a person on a water-only fast, you can expect to have a bigger effect size than any other intervention that has been demonstrated. If people start off with more moderate levels of hypertension, their drops are proportionally smaller. But of those 174 people, all 174 were able to achieve blood pressure low enough to eliminate the need for medication. After we were able to publish that first paper, we did a second study where we looked at borderline hypertensive patients, patients that didn't have blood pressures high enough to justify the risk of medication, but were still at substantially increased risk of dying as a consequence of their elevated blood pressure. And sure enough, we found that it worked in them just as well. There was a paper prepared for Clinical Nutrition Updates where they reviewed our data from our previous studies, and they concluded that fasting was a safe and effective way of regulating blood pressure. Some years ago, we were approached by the International Union of Operating Engineers. It was a large labor union in California that decided they wanted to make fasting a fully covered medical benefit for their members. And over the next 10 years, we were able to admit over 100 of these gentlemen. And we did a study looking at what happened to their members when they underwent fasting and hygienic care. And in this study, their average stay was 3 weeks at the True North Health Center. They lost an average of 26 pounds during their stay. Their systolic blood pressure dropped by 30 and diastolic by 11. And on one-year follow-ups, they were down 28 pounds and had maintained much of the benefit that they had seen in their blood pressure drops, which meant although they probably weren't perfect on their dietary compliance, they did well enough to at least sustain the benefits that they had achieved. And when the costs of care were looked at, that is the cost of medical management of these patients prior to the study, and in the year after the study, it turned out they saved more money than the entire cost of the program, which for them was, of course, a very attractive benefit. It turns out it's actually cheaper to get people healthy than it is to treat them after they become sick. Imagine that. Currently, we've spent the last 2 years working on what's going to be called a prospective study. That is, where rather than a retrospective analysis, we're doing a prospective study where patients will be admitted with obesity and hypertension. And we'll be looking now at very sophisticated markers. We've received some funding that's going to pay to look at biogenetic markers and proteomics, carotid ultrasounds, functional endothelial testing, and most importantly, long-term follow-up. We're going to be tying that into our True North kitchen model where we actually make and deliver food to people. So these people will go through the program, but they'll also be given their food for an ongoing basis during follow-up. And we expect that that's going to increase compliance and ultimately our results. This will be the beginning of what we hope will be many studies. There's actually a gentleman that is funded by the National Institute of Health. His salary is paid from a grant, and he's decided to make pursuing this type of data collection his career focus. And so he'll be joining our staff and hopefully moving us forward in a very serious way. What we're talking about, as Dr. Burton explained to us, when we talk about fasting is the complete abstinence of all substances except water in an environment of complete rest. It's important that we remember that resting is a critical component in fasting, because even if you have moderate activity in fasting, you will increase caloric utilization as much as 100%, and concomitant protein utilization as well. People often wonder, can thin people fast? But even a 70-kilogram male, which would be a 154-pound male, would have on average 12.6 kilograms of fat reserves. And if you know that that's about 18% of body fat, which is a pretty lean male in society today, using a basal metabolic rate of a calorie per kilogram per hour, that would equal a 70-day fuel supply. So even a relatively thin person would actually have reserves to fast far longer than what we usually do in most clinical situations. However, if you increase activity inappropriately during fasting, you can dramatically speed up the utilization of both your nutrient stores as well as your energy stores, and that can get people into some trouble. The 4 phases of fasting are, the first you already know, it's the gastrointestinal phase. That's when you use up the stuff that's in your gastrointestinal system. And that can take 6 or 8 hours. Then the body begins to utilize glycogen stores. And through this process of glycogenolysis, enzymes are used to mobilize these sugar stores. You store glycogen in your muscles and your liver. Has anybody ever run a marathon? And about 20 miles they talk about running into something, running into the wall, which amongst other things probably is associated with depletion of glycogen stores. Your body then has a process it begins called gluconeogenesis, where it'll break down protein in order to elaborate glucose, so that your brain, that big bulbous neuronal net at the end of your spinal column, that your primary burner of glucose has some fuel to continue to burn. And superimposed on all of this is a process of ketosis, where the body begins to shift from burning glucose to burning the byproducts of fat metabolism, or ketone bodies. Now, humans are very unusual in this regard. Most animals don't do this, where the brain as a biofuel mechanism can shift from burning glucose to burning fat metabolism byproducts called ketones. For example, chimpanzees. Although we may share many genes with them, they can't do this. They keep burning glucose, which is why you can't fast chimpanzees for long periods of time. They'll die. But humans can, because in our past, it was necessary that we had the ability to sustain this very disproportionately large brain with some type of fuel. Because what would have happened to our ancestors if we couldn't have shifted over to burning fat in order to be able to sustain our brains? Spring would have come late one year and we would have all died. But we can. We have these processes. And when we talk about fasting, what we're doing is we're relying on this very natural process. This is a biological adaptation. That means you are designed to be able to fast. And what hygienic practitioners have found over the years is that by allowing this very natural process to be induced, you can actually speed up the process of mobilizing and eliminating a lot of these accumulated intermediate products of metabolism that build up inside the system and inside the cells that can limit health. So it's just a way of giving the body a chance to do what it does best, which is try to heal itself when you get out of the way. Fasting is an efficient way of getting out of the way. Essentially, this biochemistry of fasting is about how can you draw in your fat stores, conserve your protein reserves, and survive until food comes along. That's what it's basically about. There are indications that tell us that fasting might be appropriate. Things like the loss of appetite that characterizes acute disease, having an acute or a chronic illness, if you're trying to speed or accelerate healing, to change behaviors, and also psychospiritual issues. There's very few religions or spiritual paths that don't have a tradition of fasting somewhere embedded in there, and there's good reason for that. When we're trying to decide, is a person an appropriate candidate for fasting, it's important there be a complete medical history, a physical exam, and laboratory evaluation conducted. You need that to get enough bits of data to know if that person is an appropriate candidate for that type of intervention. Not everybody at every time is fasting going to be the appropriate behavior to engage in. So there's different tests that we use routinely that are useful for us at creating a baseline. Part of what we're trying to do is determine, In the process of fasting, people will exhibit varying a variety of symptoms. And the trick is differentiating a positive symptom that's associated with healing versus a sign that the body's in trouble and needs a little bit more support. And so the use of the exam history and the laboratory testing provide a reliable means of looking back and kind of guiding whether or not a person's moving in the direction that we expect that they should. Now, when a person chooses to undergo fasting, there are a number of characteristic symptoms that come up. For example, for those of you that have fasted before, sometimes you'll experience a foul taste in the mouth. Some people refer to it as faster's mouth. And it's been described as if something crawled in your mouth and died. Sometimes people experience increased body odor. It gets so bad they don't even want to be in the same room with themselves. Sometimes they experience fatigue, even profound fatigue during a healing crisis that happen in fasting. Sleep disturbance. They may not sleep very well during the fast.